So thank you, Otto, for your presentation and questions. And now we're going to go over to the picture at Norway and hear from Sahar about what's going on there. So I'll let you introduce yourself and tell us a little bit more about what's happening. Thank you.
Thank you so much, Mark. Thank you for inviting me. It's an honor to be part of this session and discuss continuity of care with you guys. My name is Sahar Pahlavanyali. I am a medical doctor, a GP trainee, and currently a PhD candidate at the Department of Global Public Health and Primary Care, University of Bergen, Norway. And currently I'm working on a project called Continuity of Care in Norwegian General Practice. Just try, yeah. I'm over on onto the next slide, right?
Yes, that's right.
Yeah.
Carry on, Sahar. Thank you.
Thanks. In this short presentation, I'm just going to take you through the background of general practices, what general practice is like in Norway, and current research on continuity of care and which direction are we traveling to in Norway right now. Norwegian general practice is, in addition to out-of-hour services, managed by municipalities in Norway. Generally, primary care is managed by municipalities in Norway. And in 2001, the Norwegian government introduced the RGP scheme, letting all their residents to choose their preferred GP. By that time, 87% of Norwegians got their first choice of GP. And currently there are around 5,000 GPs in Norway. 98% of the population is assigned to an RGP, which makes it around 8-9 GPs per 10,000 residents. This varies, of course, depending on the level of urbanicity and where people live. Most of the GPs in Norway work in small groups of 3 to 6 doctors in each practice. Research on continuity of care in Norway has increased, especially in the past decade. In my research group, we have published an article in Family Practice last year, where we investigated continuity of care for patients with chronic diseases. This was an observational study where we used data from several national health registries and investigated whether patients with some selected chronic diseases have high continuity with either with their GP or in a specialist healthcare. We used 2 indices, the UPC, usual provider care, and the Weiss-Buxerman continuity of care index. UPC in this case measured the number of measured continuity of care at GP, which means number of consultations at GP divided to total number of consultations. And our cookie or Weiss-Buxerman index measured the dispersion of continuity of care among different providers, because we have several different providers in both specialist healthcare and primary healthcare, both patients, GP, and other GPs working at the same practice. We found out that patients with these chronic diseases have actually quite high continuity of care compared to the existing literature and international studies. Continuity of care is around 0.7, which means 7 out of 10 consultations are with patients registered RGP. Also, this shows that continuity of care also increases with age. We are very happy with this result because many of patients, older patients, have complex conditions, and we wish a higher continuity for these patients, of course. So we concluded that GPs generally take a big part in care for patients with chronic diseases in Norway. We have also discovered that continuity is lower in the rural areas. This might be due to difficulty recruiting GPs in the rural areas. Another study from my research group is the groundbreaking study my colleague Professor Hogne Sandvik and some other colleagues have done, where they have investigated RGP patient relationship, the length of RGP patient relationship as predictor for mortality, acute hospitalization, and also utilization of out-of-hours services. This was also an observational study, and they have used several national health registries. And very positive thing and about this study is it actually covers almost the whole population of Norway, 4.5 million Norwegians which are registered with RGP. They concluded that the length of RGP patient relationship was associated with reduced out-of-hours service, reduced utilization of out-of-hours services, and reduced acute hospitalization, and also decreased mortality. And if the RGP patient relationship has lasted for more than 15 years, the risk of these occurrences was reduced by 30%. As you can see in this graph, this was compared to those with RGP for less than 1 year or less actually. Also, we are working on some other projects. We have an article which we hope to submit very soon, where we have investigated the association between continuity of care and mortality. Again, but this time we have used the two indices, the UPC and cookie, in order to measure continuity of care. And we have used consultation data from 2012 to 2018 for some selected group of patients with chronic diseases. We have also found that increased continuity of care is associated with lower risk of mortality for these patients. So we are very glad that this also supports the other study by Sandvik and the rest of my colleagues. We also have another project on continuity of care, where we investigate patient perception of continuity of care with their GP. This is a survey of 2,500 Norwegian patients where we ask questions from the patients in GPs waiting rooms, whether they value continuity of care. Because we have so far investigated mainly by data from registries, and as doctors, we are very concerned with continuity of care. So we wish to know if patients also value continuity of care. We have received data from 2,500 patients, but currently we don't have any results yet. In this project, we also investigate whether patients value face-to-face consultations or other forms of consultations as telephone and video consultations. So although we claim that we have high continuity of care in Norway, today around 160,000 patients, which makes almost 3% of the Norwegian populations don't have GP. These patients have to visit locum doctors or out-of-hours services to get help. And unfortunately, this lack of GPs and increased work pressure on other GPs is one of the main reasons for this. And of course, we don't expect 100% continuity of care, but in order to achieve and maintain 70% continuity of care, we need more GPs in Norway. And also at the same time, some practices have started using specialist nurses for example, control diabetes or COPD. And although this has not been practiced in the whole Norway, but we are afraid that these consultations without involving patients' GP would actually lead to decreased continuity of care, personal continuity of care. So we hope that we soon can have more GPs and solve this problem. Thank you so much for me. And do you have any questions?
Thank you, Sahar. That was really good and very much appreciated. It's great to see the insights into what's happening in Norway. And yeah, like you, I think we'd like more GPs, and we're also facing this issue of how continuity may be affected by having lots of different additional roles in our practices. It was really fascinating, and I was interested. You talked about a GP scheme in 2005, where you had
2001, sorry.
2001,
Yes.
which had introduced GPs, and we tried a similar thing in the UK, or the government did, where they said they wanted a named GP for everybody over the age of 75, but it didn't actually seem to make a difference. And in our country, I think what happened is people gave a named GP, but they didn't provide that encouragement to see the named GP. They didn't work towards it, which is what we think is a key message. So why do you think your scheme in Norway seemed to work and get that such a high level of continuity?
I would say the system in Norway works in a way that patients can't visit other practices that are their own, where they have their own GP.
Yeah.
So they actually have to visit that practice, and usually these practices are quite small practices. Around 3 to 6 doctors working in those practices.
Yeah.
And usually every doctor or every GP is supposed to follow up their patients. So when a patient with diabetes goes to their GP, and if they need an appointment for control, for follow-up in half a year, the appointment is usually given by the GP.
All right. Okay.
So that's why it increases the rate of follow-up by patient's GP, because at the end of consultation, they agree on an appointment, and patient knows when they next time they are going to their GP.
Yeah. Yeah.
I would say that would increase continuity of care.
Good. Well, that's good. I think what happened in the UK is people were so busy that they just named the GP but didn't carry it through to give the continuity that we'd like to see. And are you seeing a fall in continuity, do you think, now, or is it something that you're not sure about yet?
We see, because we have some new data and a new article which is not published yet shows that there is continuity of care is a bit reduced compared to just some years ago.
Yeah.
Because GPs are under work pressure and we lack GPs.
Yeah.
So we say that continuity of care in Norway is also decreasing.
Yeah. Okay, so I think that's what's happening in the UK, and I'll be telling you in a minute about how we've managed to maintain or increase continuity in some practices when the UK trend is down. And it's fascinating to hear about the perceptions and the fact you're doing the survey on perceptions. And in the UK surveys we've done, we found that continuity provides satisfaction for the patient and for the staff and for the GP, as I'll tell you in a moment. But yes, very interesting to see that you've got a high rate of continuity. That 0.7, 7 out of 10 consultations with the same GP sounds really good. And to hear that after 15 years of continuity, you get a reduction of 30% of a range right across the board, out of hours, hospital and mortality. So it's quite a big change and a dose response change as well. So that's great. So thank you very much. And I'll open to the audience for questions generally, and I'll look forward to seeing what they say. But thank you again, much appreciated.
Thank you so much.
Thank you.